name is Christopher Trigger. I'm one of the core faculty members at Lakeland Health. We're going to talk about wrist x-rays today. This topic is extremely important as a lot of residents struggle with reading wrist x-rays. The complexity of the bony structures as well as ligamentous structures that do exist become problematic when there's an injured wrist. So hopefully we get through this and you'll learn something from it. So we'll dive right in. But to start, the rules for success with any x-ray is to know which views you need, know good images from bad ones, read methodically, know the common lesions, and also know the commonly missed lesions. And when in doubt, you can phone a friend and call the radiologist if available. So standard wrist series is a posterior and anterior, is the first image that we see. The wrist itself is the 8 carpal bones, the distal radius and ulna, as well as the proximal aspects of the metacarpals. Obviously, the 8 wrist bones that were taught in medical school and the mnemonic a lot of people use still applies and is extremely important. Knowing the bony curvatures and arcs of the wrist are extremely helpful, which we'll go over. This is a normal oblique view. Obviously, there's overlying bones in this view, so you're not going to be able to view all of them during the oblique view, but there are a lot of structures that become more prominent and or more concerning if abnormal on the oblique view. This is a normal lateral view. This is important for several reasons regarding alignment of the proximal carpal row as well as the distal carpal row. So first we'll start with the arcs, the carpal arcs. It's known as Gila's 3 carpal arcs. It refers to the first and most proximal arc is the scaphoid, lunate, and the triquetrum, as well as the pisiform. That's the most proximal arc. Then distal to that is the second arc, which is just the distal aspect of the scaphoid, lunate, triquetrum, and pisiform, and the third arc would involve the capitate and hamate. This is a normal view of these 3 arcs, and it's extremely important for the alignment that we are going to focus on in these later abnormal x-rays. And on the lateral view, as I talked about, there's 4 C's of the lateral wrist. Basically, it refers to the proximal as well as distal C of both the radius and lunate, the proximal, and then the distal aspect of the radius and lunate, and then the next or third C would be the lunate with the capitate, the proximal portion of it, and then the fourth C is the capitate and lunate junction. And the angle that is shown here is what the scaphoid should normally face, is 30 to 60 degree angulation. So we'll start with some wrist x-rays. This is the first one in the series. Obviously, there is a distal radius fracture, which appears to be comminuted, but more so in the lateral film, what you want to look at is the arcs that we just talked about, as well as the C's. Obviously, these are all disrupted. The proximal arcs are abnormal, and you can see that the lunate is out of proportion in regards to the capitate. So this is concerning for a distal comminuted radius fracture with a perilunate dislocation, which is important. And then the next x-ray that we have is another abnormal x-ray. This is fall on outstretched hand, extremely high mechanism injury. And you can see that the arcs are abnormal in the PA view, as well as the C's that we talked about are abnormal in the lateral view. You can see the lunate is spilled over as a teacup, and the capitate is posteriorly or dorsally displaced in comparison. So this is a true lunate dislocation. And describing it would be a volar lunate dislocation. A dorsal lunate dislocation is extremely rare and is not as common. So here's a good comparison view. The red describes the lunate bone, or excuse me, the capitate bone. The blue is the lunate, and the yellow is the distal radius. So you see on the lateral view how these C's, these 4 C's are displaced in this. So the perilunate dislocation, the lunate still has its articulation with the distal radius, where the capitate subluxes dorsally. In the lunate dislocation, the lunate bone is spilled forward or displaced anteriorly or volarly, and then the capitate dorsally is displaced, which then aligns or sits within the distal radius articulation. And that is definitely an X-ray that you most likely will see on your board exam, so knowing the difference is extremely important, although both are treated the same and can be reduced in a similar fashion. Our third X-ray, we're looking at both an PA oblique and lateral view, which you see a small avulsion fracture on the lateral view, which is the only view you're going to be able to visualize this injury, which is a triquetral fracture. So this is a fall on outstretched hand with normally hyperextension of the wrist. All the other views, the PA and oblique, you won't be able to see this fracture fragment, and the lateral is your preferred X-ray. And this is treated with a dorsal block splint and should heal very well. And this is the second most commonly fractured carpal bone behind the most commonly fractured bone, which is the scaphoid. It's best viewed on the lateral view, and we talked about the dorsal splint to block wrist extension. Our fourth X-ray, this is a radial styloid fracture. This typically is from direct trauma, and the radial styloid fracture does have an eponym, which it is known as Hutchinson's or Schofer's fracture. This fracture is important because it does extend across the scapholunate junction, which can disrupt the scapholunate ligament, which is another high-risk injury that we deal with in emergency medicine. The scapholunate dissociation, which if you look at the prior film here, it does not appear to be widened. 2 millimeters is the normal distance between the carpal bones itself, especially the scapholunate junction. And the scapholunate dissociation is typically greater than 2 or 3 millimeters, and this is known as the Terry-Thomas sign. We will talk about some special views as well. This view itself is a carpal tunnel view. This is looking for a hook of hamate fracture. This is the test of choice if evaluating a hamate fracture. These patients tend to have extreme tenderness while palpating the hamate bone in the palmar aspect. Another view is a clenched fist view, and this is a good comparison film. You can see the left wrist appears to be normal, but the right, the scapholunate junction width is greater than probably 3 millimeters, so that is more concerning. And with a clenched fist view, that junction will widen even more so. So now we're going to kind of review as we've gotten through all of our X-rays. So we'll go over each of the bones. So we'll obviously start with the radius, and then next we move to the ulna. Those are fairly straightforward. Then let's get into the carpal bones. We're going to talk about, that would be the scaphoid bone, and then we have the lunate, and then we're going to the triquetrum, and then the small little guy here is the pisiform. So that's the proximal row. And then let's talk about the distal carpal row. So first, we have the trapezy thumb, or the trapezium, and that's an easy way to remember it. Then you have the trapezoid. Then you have the capitate, and then you have the hamate. So in review, those 8 carpal bones are extremely important to remember. I know the mnemonic everyone uses, which is great, and they can continue to use that, but every now and again you forget. I do like to point out that the trapezothumb was taught to me by one of our residents, because I was always remembering it by alphabetical order. Trapezium comes before trapezoid, but trapezothumb makes much more sense, so that's what articulates with the base of the first metacarpal. And then on your oblique view, we can label once again. Obviously, we have the radius. And remember, these articulations are extremely important as the function for the patient becomes detrimental in distal radius fractures. So let's label the scaphoid bone here, and then you can see the upright cup of the lunate. Then you have the triquetrum. Here you can't see the pisiform bone, but here's the trapezium. And then here you have the trapezoid. And then you can kind of see this big blob, which essentially is the capitate. The hamate is hidden as well here in this oblique view. So we'll move on to the lateral view. And we'll label again, just so we're clear with what we're seeing. So we have the radius here. The ulna is kind of overlaid by the radius itself. You can obviously see the 4 C's, which I think we should talk about on this lateral wrist. So we start with the first C on the lateral wrist, which is the radius and lunate junction, the proximal aspect of it. The second C is the radius and lunate junction, the distal aspect. The third C is the lunate and capitate, the proximal row. And then the fourth C would be the capitate and lunate distal row. These 4 C's are important for the alignment of the lateral wrist. Here we're looking at the lateral wrist. We see the radius, the ulna, the trapezium, the capitate, and the lunate in relation to the 4 C's, and you also see the hamate bone. And that is the review of the lateral wrist. Thank you so much for your time and patience while watching this lecture series.